Good afternoon, everyone. I apologize for the slight delay, but we are ready to get started. Thank you for joining us in person and on Zoom. My name is Alexis Smith, and I'm the Educational Exchange and Event Program Manager with the Office of International Programs. And I can't believe it, but this is the final installment in Foundations of Global Health in conjunction with the International Orthopedic Trauma Collaborative. And just a little bit about Foundations of Global Health. Global health is an area for study, research, and practice that places a priority on improving health and achieving equity in health for all people worldwide. Global health emphasizes transnational health issues, determinants, and solutions, involves many disciplines within and beyond the health sciences, and promotes interdisciplinary collaboration, and is a synthesis of population-based prevention with individual-level clinical care. And that comes from the Consortium of Universities for Global Health. Global health is a varied and rich discipline to which many healthcare providers, researchers, and faculty aspire to being professionally engaged. With our being a globally connected world, this ongoing programming through the Office of International Programs is designed to feature those in our KUMC community engaged in the field of global health. KUMC's faculty, researchers, and clinicians, our international partners, and our community partners. Presenters will share their personal journeys, educational backgrounds, mentors, books, and articles that gave inspiration, challenges, lessons learned, successes, epiphanies, life-changing moments, and even the heartbreaks. The series is meant to provide a platform for both presenters and participants to participate in conversations while developing foundational knowledge and exploring best practices for engagement in the discipline of global health. And while this series is concluding, we do have a Foundations of Global Health on Thursdays. On Thursday, Breaking Barriers, Clinical and Public Health Approaches to Cancer Control in Kenya, and that is by Dr. Gregory Ganda, and he is actually coming in tonight. So I will now turn it over to Megan.
Well, good afternoon, everyone. We truly appreciate you all being here with us today for the final lecture in this lecture series. My name is Megan Lemons, and I'm a third-year medical student here at KU. I'm honored to introduce today's lecture, which will focus on the management of pediatric trauma. Over the course of this lecture series, we've explored numerous facets of the global trauma epidemic, an issue that continues to impact millions of lives around the world. We've discussed what orthopedic trauma is, and have examined the vital work being done by the African Trauma Initiative here at KU in order to address the lack of access to orthopedic trauma care, particularly evident in low and middle income countries. We've taken a closer look at the contributing factors to this crisis, including road traffic accidents, work-related injuries, conflict, and self-harm. We've delved into the unique complexities involved in treating trauma in resource-limited settings, and we've explored how religion, personal beliefs, and mission-based organizations shape healthcare infrastructure and can be powerful forces in driving change. We've also emphasized the critical role of the entire healthcare team, including nurses and other allied health professionals, in improving outcomes for orthopedic trauma patients. And we've reviewed current conditions in several African nations where our organization is actively collaborating. Today, we'll bring this series to a close with a focused discussion on pediatric trauma care. Treating pediatric patients in trauma settings brings unique challenges that differ significantly from adult care, and these challenges are only amplified in under-resourced healthcare systems. With all of that being said, it's my pleasure to introduce Dr. Betty Casa, pediatric intensivist practicing at Children's Mercy Hospital, and Dr. Stephanie Kukura, neonatologist, also practicing at Children's Mercy, who are both experts on this topic.
Good afternoon, everybody. I hope you could see me, but just listen to my voice. It's a pleasure to be here. My name is Betty Casa, and I have until very recently, I've been practicing as a pediatric intensivist and pulmonologist in the Gorambasa in Ethiopia. So I have a unique perspective on the discussion today. So both presenters, me and Dr. Kakura, have no conflict of interest to disclose. And with that, I will try to go through this as quickly as possible. So first of all, what is childhood trauma? So it's injury resulting from external physical forces in children under the age of 18. And it could be from many things. It could be fractures, it could be head injuries, burns, lacerations, internal organ damages, or and basically we divide it as intentional and unintentional. Usually the intentional ones are abuse and violence. Those are the kinds of trauma that cause long-term complications or like psychological impacts as well. And when we talk about trauma, we need to know that it's the leading cause of morbidity and mortality in children worldwide. And 10 to 30 million children and adolescents experience injuries yearly, of which around 1 million end up in death. And traffic accidents are the major cause, accounting for almost half of the cases. And children under 5 usually are the ones that get the majority of the damage from this problem. In the African context, it is a very high burden, and children are much, much more vulnerable with injuries, and most of the injuries are generally preventable injuries. And this happens around 95% of the trauma deaths happen in low and middle income countries, which the majority of which are within the African continent. And the rate of unintentional injuries in children in sub-Saharan Africa is very high, as you could see here. It's around 53 per 100,000. And this distribution can show you how most of the African countries are very high burden for trauma and injury in general. When we're talking about injuries earlier, we say there are intentional and unintentional ones. Specifically, intentional traumas have much bigger long-term repercussions for them, and these are called adverse childhood experiences. They not only have physical impacts on children, they also have emotional impacts that last a lifetime. And this could be manifested in the form of sexual abuse, physical abuse, exposure to violence through witnessed deaths, war and neglect. These are usually associated with high conflict areas such as most African countries. This is a sub-Saharan Africa stat. It's a little blurry, but I hope you can see it. So the commonest reasons for injury or mechanism of physical injury are generally road traffic accidents, just like the rest of the world. But there are some obstetrical injury being very predominant, which is not common in the rest of the world. And domestic violence and things like that are also prevalent. Again, when we were talking about the prevalence of AECs, we are talking about sexual violence as well. And that is very high, as you can see in the continent of Africa here. And not only girls, but boys are also exposed to such violence. Now, we said a lot about this, the data and the statistics, but let's come to ground this in reality. I want to show you a case that I've seen a few years back and how it impacts management and approach to children with trauma. Before I say much about the case, I want to show you a little bit about where this happened in the setting. So this is from, as I said earlier, I am from Ethiopia, and that's where I was practicing. Ethiopia is an East African nation with a population of around 129 million, and the climate is usually very great throughout the year. And it is one of the only 2 African countries that was never colonized. So the people are very proud, as you can imagine. And it's a very multicultural country with around 80 different ethnic groups and around 200 dialects being spoken in the country. And it has been a continuous country, a continuous civilization for the last 3,000 years. And Addis Ababa specifically is the place where I was practicing again. And it is the diplomatic capital of Africa. It is a very populated city with around 3.5 million people living in it, and it is a very high altitude area. The biggest problem with Addis Ababa is the fact that the roads are insanely like disorganized. People cross while cars are driving. Here I can play the video. So you can see people are walking and the cars are driving. There's no traffic lights, so it's very hard for people to kind of it's very easy for people to go into an accident. You can see here, people are driving between the cars are doing their own thing. They have like no rules. Basically, it's the Wild West out there. So that has an impact, as you can see. And the Ambassa specifically is one of the biggest centers in the country, and it usually takes care of around 800,000 patients per year, and most of those patients are children. Around 45% are under the age of 5 and under the age of 15, excuse me. But even in that setting where we're seeing so many children our ICU beds are severely limited, and there are only 8 pediatric ICU beds and 2 neonatal ICU beds that are properly equipped and with ventilators. And in the country, again, road traffic, the commonest injuries are road traffic accidents. You can see here, falls are there as well, and interpersonal violence is one of the other reasons for trauma. This goes in line with the African data. And again, children under 5 get the, like short end of the stick, and they are the ones that are being severely affected. War, again, is one of the biggest reasons. In the northern part of the country, there's a lot of conflict, and that also plays a huge role in what's happening in that setting as well. So now we come back to our case after I say all of that. And it's a 4-year-old boy who lost consciousness. He presented to us with loss of consciousness and bradypnea of 2 hours. He was hit by a car while he was playing outside. He was not being attended. The mother was in the house. And immediately he lost consciousness, and he was brought to the hospital by the owner of the car while he was being carried by his mom in her lap. So you can see here how that presentation really could affect the child adversely. At presentation, he was bradycardic, and he had multiple lacerations, bleeding, and his consciousness was severely affected as well. So what happened next is the biggest problem. Now we can start to see the problem. Number one, the way he presented, obviously. Number two, the severe trauma. He was diagnosed with severe traumatic brain injury with raised ICP. Clearly, he needed airway protection, but the ICU was not available because we only have 8 beds. So now we had to intubate the baby, and people were taking turns bugging him because there's no ventilator. You can see how the damage would come from that. So many things with, like just basically guessing how much ventilation the baby is going to require. And then finally, after 12 hours, he was admitted to the ICU, but the vent that he was on was not cleaned properly because we didn't have time to take it from the extubated child and then put it for him. So he developed ventilator-associated pneumonia, and then there was diabetes insipidus from the head trauma. Now, to discharge him, it took us 2 months because, again, he was supposed to be on medication for the diabetes insipidus, which the parents couldn't afford, so we had to keep him in the hospital, and then he developed another infection. By the time he left, he had lung scarring and bronchiectasis. Now he has lifelong complications from the trauma, which could have been avoided. So from avoidable trauma, he's going to have a lifelong chronic complication. No, so what are the challenges that we faced here? There was no efficient transport. Initial assessment was not being done. The baby was brought by hand, which could compromise the airway. There was poor acute care facilities, no specialized staff at the time of the trauma. So he was transported by somebody who was not trained to care for kids who had undergone an injury. And there was no comprehensive infrastructure when he did come to us for us to care for him properly. And then afterwards, there are no rehabilitative services that are going to help this child live a relatively normal life. And the biggest issue here was the poor preventive strategies as well. So children being left unattended, it's a cultural thing. Children usually play by themselves. They're encouraged to be outside while there was nobody supervising them, things like this. These are things you could fix with education, and it's something that's easily fixable. And the other problem, which we did not face on this specific case, is delayed presentation. So most of the time, families tend to take kids to the traditional healers to get those broken bones fixed, and there are malalignments and there are growth plate damages, and then they do come after a few months where it's really hard to fix the problem that has already occurred. So again, these are things that we've already mentioned. So how do patients present in Ethiopia to the hospital after trauma, after injury? So most of the time, only 11% of patients present with an ambulance, with first responders being present at the time. The rest of the time, they come through cars, they come to public service, things like that. And the damage, the injury is getting worse throughout that process of transportation. And even after they come to us, we have issues with OR. So in our operating theaters, there might not be surgeons available because there's one surgeon for the whole hospital. He's tired and God forbid, he wants to sleep for a few hours. Or there isn't a proper anesthesia care provision, or there isn't, availability of proper equipment to go to the OR, or there's poor handover and communication issues as well. So these are things that we've seen so far in as barriers to proper care. And what are the implications? The impacts of injury are deaths, hospitalizations, permanent disabilities, as we mentioned earlier. And for the clinicians, there's burnout and distress because these cases keep coming, and the care that we provide is substandard. Other impacts of ACEs are long-term negative health outcomes such as mental health problems, depression, suicidality, and other things in these children as they grow older. So what interventions can we do? We can do prevention, we can do management, and we can do policy changes. So we will try to see a few of these and how they work for the rest of the continent of Africa and how we can implement them. So when you talk about community education and awareness, as we said earlier, it's very important. Prevention is very important in the setting of Africa. Some examples that really worked with education is a community-based education program in Zimbabwe showed there was a 50% decrement in burn accidents just from health education. And a child safe programs, which are widely implemented in South Africa by the Red Cross Hospital, shows that road traffic safety tips and school safety tips have improved significantly the number of trauma and injury that was being reported by the centers. The other thing that you could do as a preventive step is safety initiatives, right? So some of the safety initiatives introduced that really made an impact are introduction of speed bumps in Ghana, which decreased 50% injury reduction. School zone speed regulations in Kenya did the same thing with significant improvements. So these are things that we've seen time and time again work in Africa, and we can implement them. So prevention is the best way to go because fixing the healthcare infrastructure is really hard in the setting of Africa. And some other home and school environment safety tips that were being done in Uganda showed that, like when they were taught proper cooking and hygiene practices within the house, the burn rates were also decreasing there as well. The other thing we could do is improving management strategies with the resources that we have. So what are those? The WHO has almost for the past decade been trying to roll out something called the emergency triage assessment and treatments. So that is to see which babies are at the highest risk of dying from waiting in the waiting room in the hospital. So they get prioritized. This worked tremendously well in the hospitals that was implemented, and it shows 20 to 40% improved survival in injured children. And I feel like implementing it nationwide is one of the best ways we can kind of improve our outcomes. And establishing child-free trauma protocols are also very important. Access to physiotherapy, if available, that is going to make a huge difference. Occupational therapy and all those things would be another important thing. Last part is policy, right? So when we're talking about policy, we are talking about national injury surveillance systems. We really need those. We've seen that injury surveillance systems in South Africa has improved significantly the outcome of kids because you finally identify where is the problem. So you want to tackle it specifically. And enforcing child protective laws such as seatbelts, helmets have again shown improvements in countries like Malawi. And integration of efforts across health education and transport sectors, that is also very important. You can see transportation issues are one of the biggest reasons we see injury. And that is something that we need to work on as well. So with that, I think I'm gonna move the discussion to Stephanie, who's going to be presenting the ethical and moral issues regarding trauma.
All right, thank you for that start. So now that we've sort of talked about what the challenges are, I'm going to talk a little bit about the ethical issues that are related to pediatric trauma that also come across. So the first issue, as we sort of have heard, that is in low and middle income countries, there are challenges of limited resource allocation. The bioethical principle of justice suggests that limited therapies should be distributed fairly, and that the cost of medical therapy, and here in the US, the cost and availability of medical therapy is rarely prohibitive. But these things are really common in low and middle income countries. And these are not only like equipment and supplies and medications, but things like trained healthcare providers, beds, and OR time. And so thinking about how to thoughtfully distribute these to trauma patients, and especially to those who will benefit from them, is really complicated. There are lots of different schemes that people suggest. Is it first come, first serve, whoever arrives first? Is it whoever the worst off? Is it the number of lives you can save or the life years you can save? That matters a lot in pediatrics, because if you can save a young child, they have a lot of years ahead of them compared to an elderly adult. And then thinking about sort of the instrumental value of patients, thinking about like what's important for society. Okay. Beneficence, as we all know, is that we all strive for actions that promote the well-being of others and try to serve the best interest of patients. We should try to do the most good in every situation, but what's optimal for one patient may not be optimal for another, and we consider these situations individually. And I think in the setting of trauma, this is especially important because a lot of these patients are not sort of conscious, awake, or able to talk about what it is that they want, and especially for pediatric patients whose parents may not be there. It's very hard to sort of decide. On the other side of beneficence is non-maleficence, to not do harm. And that means we should avoid doing harm to patients, but sometimes we do treatments that are intended for good that unintentionally do harm, and there are double effects to those. Autonomy is the right for individuals to self-determination. So patients get to make their own decisions, and informed and competent adults are able to refuse or accept treatment, drugs, or surgeries according to their wishes. But children are in this country sort of limited in that because of the child protection laws. But as you can imagine, in a country that has fewer or limited child protection laws, deciding when there's a conflict between, you as the clinician and the parents about what should be done for a child who's been seriously injured, there might not be easy ways to resolve this. I'll sort of skip this, but this just sort of says, like in pediatrics, we don't sort of have people who can give you their own opinions about what they want for them. And we also can't, like we would for other adults, say, well, this is what they would have wanted, because they've never expressed their values. So we generally think that parents should make these decisions, but sometimes this is complicated. So again, beneficence and autonomy and trauma, these are decisions that have to be made really quickly. When a trauma patient arrives, usually the idea is to start getting them treated right away. The patients aren't able to provide information about their values and preferences. Their family or surrogates may not be present. There's not a lot of legal guidance on what the best interest is for children in Ethiopia. Families often shoulder the costs of care for these patients. And so this can have a big effect not only on the patient, but also the family, other children, things like this. And of course, the outcomes that you have can have serious lifelong implications. Communication is a big part of this. And usually when there is a pediatric trauma, there is bad news that has to be communicated to families. Information that alters the patient or family's perception of the future, a diagnosis, a prognosis, a complication, and an error. And we know that how news is communicated impacts patient care and well-being. Well, these slides didn't come out super great, sorry. Some aspects of these conversations are like, what's the nature of the news? Whose fault is it? How hard is it to explain or to understand due to some of the medical complexity? What emotional reactions might the patient or the clinician have to having to be part of this conversation? The relationship and status between the doctor and patient. So, in different countries and different cultures, how they interact might be really different and shaped by that culture. And then, of course, the patient or family's expectations or understanding. So what is the news? How bad is it? Is the patient dying, or will the patient just need surgeries? Will they have lifelong differences? Is this the final news, or are things still changing? Can they get better? Can they get worse? And what are the differences in how sort of bad news or bad outcomes are perceived? Does the giver know that this is bad news? Does the receiver understand that this is bad news? Is someone responsible for it? Is this an error that's occurred? Is this a problem that's worsened because of the treatment that was received? And sometimes these conversations are more difficult if it's felt that there's remorse, regret, or shame associated with it. There's often a lot of uncertainty in these situations. Not enough information, not enough understanding of what the future outcomes could be or the likelihood that they could happen. And personal uncertainty about what the significance of specific risks are to individual patients. So we actually had done a study. This is a different context. This is neonatology, because that's where I usually do my work. But we actually talked to interprofessional clinicians in the NICUs in Ethiopia and Ghana to understand how they communicate serious news. And the sort of basic things that we found was that there were a lot of barriers to giving serious news. There were resource limitations. People would say, well, we don't really have all the things that we would need to make a diagnosis or tell them a prognosis. We just don't have enough people, or we don't have enough time to do it. There's not a space to do this. It's a very crowded, we don't want to tell parents bad news in the middle of a very crowded waiting room. And the parents might not be at the bedside, and there might not be an easy way to reach them. There are also cultural differences. We don't really understand or see eye to eye on things. It's hard for us to share, news to them. There are language barriers. As we said, there are 200 dialects in Ethiopia. Finding someone who speaks the same language can be a challenge. Gaps in education and health beliefs of what parents understand. And how they internalize this news. And then there was also a social and emotional aspect, a fear of traumatizing parents, a fear of their emotional response, worries about their reactions being sort of like big and distressing to other people around them, and fear of undermining the trust in their healthcare team. So I won't read all the quotes because I want to keep us on time, but we can go back to them if people are interested. We also found that there was a sort of asymmetric feeling about sort of talking to the two parents. There was a higher reluctance to tell the mother, and that was partly because the clinicians perceived that mothers had sort of more emotional frailty, and also there was a lot of pressure from her family, like, don't upset her right now. This is not a good time. But this actually led to the mothers not being very well informed, and then they were sort of excluded from decision making, and that caused big gender disparities in decision making for neonatal patients. So the barriers led to delayed sharing of information, miscommunication, and misunderstanding, as well as reluctance to engage in serious news conversations with families, and that's problematic. The idea of futility, also known as non-beneficial treatment. So there's both sort of quantitative, nothing that we can do can save this patient's life, and qualitative, even if we do all these things, this is not a life that is worth being saved into. Clinicians are not obligated to offer any interventions that are felt to be futile or non-beneficial, but there can be disagreement about the likelihood of and desirability of outcomes between clinicians and families. And then there's also this problem of the self-fulfilling prophecy. If you decide that something is not survivable and then you don't offer those interventions, then patients don't survive. And then you're like, great, because they would never survive this, right? So even our sort of outcome data can be tainted by the decisions of what to offer and what to pursue. Finally, moral and ethical distress. Providers experience different kinds of ethical stress. I don't know what the right thing to do, or I'm complicit in care that's ethically wrong. And clinicians can suffer psychological harm stemming from moral dilemmas where people are torn between competing ethical principles and not sure what the right thing is to do, or moral distress, feeling like you know the right course of action, but you're impeded from taking that, and that's causing a challenge to your personal moral integrity. And you can experience a lot of moral emotions. Humans get very upset when they feel like their moral code has been violated. And this can lead to physical, emotional, and mental exhaustion from long-term involvement in emotionally demanding situations. This leads to emotional and physical burden of always taking care of others in distress, and reduces ability to have empathy towards suffering in the future. So this is the sort of spectrum of burnout, compassion fatigue, and then eventually poor provision of care. And the trouble with moral distress is that it builds over time and across cases. So it's really hard to return to your original baseline after you've experienced repeated situations. So what kind of ethics education is there in Ethiopia? Well, we know that the pediatric folks encounter a lot of ethical challenges during patient care. And what we've heard is that, the ethical challenges there might be even higher. Okay, I'll pause there before I get into more if we want to have a chat.
Why don't we bring up our panel? We've got Dr. Beza and Dr. Costa. We're just going to do this for a bit because we want to make sure we've got time for people to ask questions of Dr. Kokoris. So, and then is Patrick on? You see, is Dr. Kinda on?
Yes.
Patrick, thanks so much. So, Patrick, Dr. Kinda was our third fellow, and he is you're the chief medical officer of.
Yes.
Yeah, he's the chief medical officer and an orthopedic trauma surgeon at St. John Paul's Orthopedic Mission Hospital, which is primarily a children's hospital. And so they're going to make our panel today. And so feel free to have a seat. over here, and then we'll have, Lexi's gonna moderate. Cool. Testing.
All right, hi, I'm Lexi Garrington. I'm a medical student working with IOTC today, and we are going to go and move into our panel discussion. So it looks like we already have our first question. I have a long list of questions, so if you have questions, just raise your hand. So go ahead, sir.
How do you think works really inform consent issues? Like, I think about you, you propose three very complicated issues to someone who may not be educated in the medical field. Is that really informed consent? Also, the issue where maybe some people might think doctors are gods. Whatever you say, they're not gonna sort of argue against you if they're not comfortable with the choices they have. Think more to that.
Okay, so I'll start with that one. I would say, yes, even in high-income countries like the United States, even with decisions that have a long time to consider them, there are a lot of questions about whether informed consent is truly informed, whether patients truly understand what we're proposing with different therapies, and whether they understand the patient's possible outcomes and what that would mean for them. We are obligated as clinicians to do a good job with this, but I think that the sort of idea behind informed consent has largely shifted from, making sure that the patient truly understands things to sort of protecting the clinical team from people being unhappy with their outcome, right? So I explained it to them, thinking that this is a possibility. I think that, in a trauma situation, this is like all very, very hard, right? Someone arrives and you might not be able to talk to them, you might not be able to talk to their family, you have to just sort of say, I think that this is in the best interest, and start going on it, especially in a pediatric case. But I think that, what the outcomes are, like we heard in the case, having lifelong medical needs, having lifelong differences in your, cognition and, or your disabilities and the way that you're able to like ambulate or move might have really big implications for you. And perhaps not everyone would want to go through a lot of intensive therapy to achieve some of those outcomes. But I think, in those situations, often the goal is to sort of err on the side of doing them. And then you kind of might get to the end and say, gosh, sorry, like this is where we ended up. And I think your point about doctors being gods, there's for sure differences culturally in how much the doctor's recommendation is sort of part of a decision process versus what we're going to do. And that's sort of changed in the US culture over the years, but it's also very different culture to culture, and sort of how doctors are regarded, how people think about it, how sort of the cultural, how the culture dictates that people would have conversations between sort of a doctor and a patient. And that can really impact sort of how the clinical course goes. I'll turn it over to Betty, who I think can actually speak better to that.
No, I think I agree. You say most of it, but yeah, regarding like how people perceive physicians, it depends on the culture. And for us, there's this paternalistic relationship with physicians, so it's really hard to understand they're agreeing with you because they think this is the right course of action, or is it they're agreeing with you because they just don't want to offend you or make you feel like you're not doing a good job. Sometimes that happens, and sometimes they do agree with you, and then they end up not doing what you've decided, or they kind of show you that they don't agree in other ways. So you have to be able to read the subtle ways that people give you their perspective. I think you need to be really careful with it.
Right, going off that, today, compared to some of our other lectures, we're really focused on the pediatric lens and the relationship with the patient and the doctor dealing with children. So how do you go about navigating those conversations, advocating for a child that you're treating here in the United States versus abroad, and how do the resource constraints affect that?
So I'll say that, here,
are sort of very clear rules about where, parents have the authority to guide decisions and where they don't. And while, you really have to meet like a pretty significant threshold of harm to step in with the law and say, no, we're not doing it that way, that is always something that we have the ability to do. And so the other thing is that costs don't factor in here. Generally, like all kids qualify for insurance, and we don't sort of say, gosh, this is going to be too costly. And parents never say like, don't do it because we're worried about the cost. But I'll turn it over to Betty who can talk more about it. Like these are sort of different considerations when, when you're in another setting. Generally, we do have a lot of situations where parents and clinicians disagree, even in this country. We do a lot of work trying to communicate and understand, where the differences are and work through it. We also have trained clinical ethicists who can step in and help sort of provide guidance for the team, sort of what's acceptable, what's not acceptable, and sort of how to navigate through these, which is another thing that is problematic in a lot of other countries.
Yeah, and this kind of like gives you a clear perspective. It's way harder to treat children in resource limited settings because most of the time cost is going to be a huge factor in our decision making. Remember that like these parents are not saying I don't want to do this, not because they don't love their children. In fact, every parent loves their children. It's just the opportunity to care for their children is not as it is here. So they have to think of their repercussions, the other children, how long they're going to stay, what are they going to do. So, and then there are no other ways you can advocate for these kids. Even in cases where there's like abuse or physical abuse or neglect, things like that, there are no centers where these children can be cared for. So you will have to work with them while it's available to you. So it's really hard. It becomes a huge moral dilemma. But again, there are no legal or like ethical frameworks that are clearly stated within the country, at least for Ethiopia. Patrick can speak to like the rest of Africa, I mean, like for Zambia as well. But there are no frameworks that we can follow, that we can use. So this kind of creates a huge ethical dilemma for physicians caring for children and adolescents in resource limited settings in general, I would say.
Yeah, most of the things I do here. In our country, specifically in orthopedic cases, if the parent is the one who decides for the child, and there's no way there's no legal action that they take. If the parents say, I don't want to have this care for my child, then there's no means to, give you the medical care that's necessary for the child. And there is no, even if there are the rules, there is nobody can, facilitate advocate for the child. There is no one, there's no legal action going to be taken for the parents who refuse the medical care that the child needs. That's one difficulty. The other thing is there is lack of awareness about how medicine can do good for the child. There are scenarios like patients usually, especially in orthopedic case, they wait for this so-called local prolongation or fractional consequence. So the parents prefer to take the child to these fractional consequences and rather than bringing them to the modern medicine. So most of the time, they end up in complication in managing those traumas or fractures that the child has. And when there is complication, then they come to the modern medicine. And by the time it's too late, they are either disabled enough that they cannot do anything more, or sometimes the injured limb is dead that you might go for amputation. In my residence program, there's a place which is something similar like Patrick Hospital. It's around 100 kilometers from Paris. So we used to go to Zach's Hospital and we have like small manufacturers that used to operate there. So every time I go to that hospital, there's at least I would have history of outpatient because of his neglect care. So when this child, after they have the kid, after they have the amputation, when they go back, the community will have a kind of perception that if you go to that hospital, your child is going to be amputated. So, you know, they won't come back again. Even, I don't know how to, fight for those kids. This is like that. So this is a common issue that we have in terms of
Yeah, I think in the work that we've done in the neonatal intensive care unit, like the trust that families have in the medical system and what kinds of care they'll have at the hospital is really problematic. What they'll do is sometimes they'll, as Eddie was talking about, go to see a traditional healer. And then when that's not working, then they'll say, okay, fine, I'm going to go to the hospital. But then they're so sick that there's no intervention that will work. And then the family leaves and say, well, the hospital didn't do anything, my kid still died, so like, what's even the point? And that sort of worsens trust among the community, whereas, bringing the kids sooner when we could intervene could actually really change the outcomes.
Do we have any other questions?
So I think going off that, I understand that you have to, so I understand that you have to work within the system that you have. How, in your experience, how has it worked if you have seen signs that are showing like this child is being abused or something along those lines? Like, how do you navigate that?
Yeah, so I mean, just because the system is really hard doesn't mean that we don't try. When it comes to advocating for children, we do that. I mean, for example, for pediatric emergency care, this was virtually non-existent when I was a fellow and doing my fellowship. And we did end up like advocating at the Ministry of Health, and now there are like systems that are like pediatric emergency care center practices, along with my other colleagues that work there. So there are some things that we do to do that, but like when it comes specifically to child abuse and neglect, that's an area that we have a huge problem with. There is no legally or like there are no institutions that care for children once something like that happens. Oftentimes, unless you like my hospital where it's extremely specialized, and there are a few leading hospitals where Mario is also from. In those institutions, you might actually get access for non-governmental organizations that will help you out, take care of these children. But what you need to keep in mind is we are at the, like the kind of better end of the situation where we have that access if we really look for it, we get it. But if you're, for example, working in the northern part of the country where there's a lot of conflict and children are being, like brutalized, abused, and physically injured, there are no centers where you put them. So oftentimes, this is the reality of the situation. These kids go back to the place that is unsafe to live for them. Because the other option is just take them out and put them where. So you would send them to a place that is, and then you can imagine the kind of moral distress these physicians, these people who care for these kids are going to have, because knowing fully well this child is going to come back with the same problem tomorrow. But yeah, it's a very difficult situation. I don't want to cover the reality of it. There are places where you can afford to get better, like to get access to someone else who's kind enough to care for them. But there is no system.
All right, bringing it back to you're talking about moral distress and the impact it can have on you guys as medical professionals dealing with these systemic issues. So how do you ground yourself when you're being a part in solving this trauma epidemic and the issues that children are facing?
So this, if you look at pediatric hospital traumas, most of them are like considered non-operative, but the complexity comes from in terms of infrastructure and also awareness. I'm speaking about my community, so we do have only one pediatric dedicated hospital center, which is few probably some would meet them. But if you count how many pediatric hospital centers that we have, is like probably 5 or 5,000. And some of them are really quite. And the other thing is you need infrastructure, you need more infrastructure. So we only have one, we need more infrastructure. So we need to allocate more budget on building hospitals, which is doing better in pediatric, centers. The other thing is we need to increase and we need to educate people. Like most of them are treated by general surgeons. Like I used to treat pediatric trauma as a general surgeon when I was home. The other thing is that we need to create awareness, like because the problem is immense that these traditional bone setters are everywhere. We don't have also to treat all the patients that we have. So one thing that we took as an option was to create awareness on these traditional bone setters. So there are times that we go outreach and try to teach at least not to do harm in terms of things. Like what they do is they massage it, they apply kind of bamboo string thing, wrap it very tight so that it will cause more than it will do good. So at least we try to teach them what's not to do. So there are certain programs that have been done to to teach this traditional concept and create awareness in this place. So that's what.
Yeah, and regarding how do we ground ourselves when we care for these kids, I mean, one of the things that really helped me when I was working in Flatline was after I took a pediatric bioethics program. That's how I met Dr. Kura. I've kind of got the groundwork of what we could do. So we tried to set up an ethics committee where we could actually discuss these cases, try to find ways to navigate it so that physicians don't have burnouts. I mean, at least decrease the amount of physicians that are going to have burnouts, that are going to have moral dilemmas and distress. Like create small frameworks, like when do we say this is a B-typhus, like defining utility, when do we expedite patients, and when do we have discussions with parents about palliative care, things like that. So those really, I feel like those groups that we've created and those people who were trained with me, we really did, I think, make a difference there.
So I really want to highlight that here, clinicians experience a lot of moral distress in clinical care also. But I think that the way the sort of ethical challenges that the individual clinician faces are really sort of different and more limited in a lot of ways, right? Like, I might be in the NICU and say, gosh, like, I don't think we're helping this baby anymore, but the parents want us to keep going, and we have this disagreement, and I don't feel good about the care that we're providing. But I have never, ever in my life had to look at two babies and say, which of these two is going to get the last ventilator? And I feel like, those are sort of different levels of sort of ethical distress, right? And I have a lot of training. I serve on the ethics committee, and I sort of help other, when a clinician says, hey, I'm uncomfortable with the situation, I help them unpack it, I help them think through it, and I have a lot of tools and I have a lot of guidance and frameworks. If you can imagine if you were in a place where not only are you the person responsible for who's getting this last ventilator, but you also don't have a lot of ethics education to think through, like, how might I consider this? And you don't have a committee that you can turn to and say, I don't want to make this decision alone. Help me understand, are there limits to who we will even consider, like, how do we determine the candidacy for this that will help us sort of stratify who should go first? So it's not just on me today to do this and, my colleague tomorrow to do this. So that's a lot of the work that we've been doing at Children's Mercy. We have a bioethics program. We have international folks joining us every year. Dr. Merhowit is finishing in like 2 days. Betty was one of our students a couple of years ago. The hard part is that we teach you American bioethics. We teach you the bioethics that works in sort of high-income countries, knowing that there aren't frameworks that make sense, that are culturally relevant, that consider the resource limitation. All we can do is try to help empower our colleagues there to understand, how we consider bioethical approaches and then support them as they work towards creating the frameworks that make sense in their context.
All right, do we have any other questions in the crowd? All right, I have another question here. So what we talked a little bit about different policies, how the United States has a lot of laws in place to protect children and advocate for them. However, that's not always seen elsewhere. So what changes potentially at the policy level and national, international would have the greatest impact on the outcomes that you're working with children in the medical space?
I think this is a hard question, you know, as an outsider who works in sort of the NICU space, I would love to see sort of prioritization of sort of funding towards neonatal intensive care, but also sort of maternal care and things like that, because I feel like, you know, these are spaces that are maybe not seen as cool or flashy as other parts of medicine, but have a really big impact. But I'm biased because I like the neonatal patients. But I also think that policies around sort of withdrawing supportive measures would be really, really helpful too, because I think, you know, here, you know, we sort of know that when it's not going to be effective, when there are going to be problems, like when it's time to talk to families about making different goals, you know, to prioritize, that we're sort of protected from that. But in a space where that's not as common and these technologies are starting to emerge, you know, when I started going to St. Paul's years ago, there were no neonatal ventilators, and now there are 6 neonatal ventilators. And I think we estimated, what was it, there were maybe about 20 in the whole country, which is like half of what we have going in the NICU at Children's Mercy at any given time. So if you think about how big that scope is. And before, my colleagues there never had to wonder about when was too much, when, you know, how to stop when therapies weren't working, because patients would just die. You know, we couldn't support them and they would just die. And now these questions are coming up, and with limited resources, like, you really need to understand how to shift gears and try to prioritize who's going to benefit from it. And there's not a lot of guidance for that.
Absolutely. And I feel like the one thing that we always forget to mention is in most of the African countries, pediatric care is largely neglected. It doesn't have priority. I feel like it's a lot, like in most lower middle income countries, you have the same problems. And when it's been when focus was given, was usually for infectious diseases, vaccine preventable diseases, things like that, which are very essential because 30% of the death rates under 5 came from those, and we saw a huge improvement. But what we need to understand is, as those things are going away, we have other things that we need to address and tackle in this pediatric environment. It's to a point where in most of the country, when I was a student and I was a medical student, I used to see parents come with their kids, and it's if they're under 5, there is no expectations of them surviving. They don't come with the intention this kid is going to be fine and I'm going to take him home. It's if he's going to be fine, I'm going to be very happy. So that's the mindset people come with. So you can see that this is the kind of mindset we need to change, and that's the mindset that most of the politicians who are working in these spaces have. So when we advocate, we don't only advocate for education for children in the public space, but we also need to do the same thing for the public servants who are working, and we need to make sure that children get priorities. That's the first step. And then after that, there are so many different problems and diseases that we're seeing nowadays that need specialized care. So we need to kind of say, okay, hold on, this is the same country that's doing kidney transplants and doing IVF and all this fancy CNS procedures, and we're not even having 20 beds for pediatric cases, neonatal cases. For pediatrics, the same thing. It's not that different. It's almost the same as the neonatal care. So we need to kind of come back and give priority for the people who need it, because as I said earlier, 15%, 45% of the country is under 15 years of age, and nearly 60% of the country is under the age of 18. It's a very young nation who is ignoring the young people. So, we need to work on this as well.
All right, we probably have one more question. Does anybody from the crowd want to ask?
Just curious if Patrick has any comments on all this. He's been kind of quiet. I don't know if he's busy or.
Okay. Okay. Sorry. The audition was not very good here, But what I can say just for the experience with the children with my hospital, because as Archie saying, my hospital was first designed for children. And when you speak about children, those are children with the disabilities, and that's a priority of the hospital. And where do you find those children? They are actually in remote areas, in rural areas, and definitely, and most of them means the category of children which comes, there are some with uh, deformities like clubfoot, osteogenesis imperfecta, but we have also a lot with malnutrition. Because what happened, it's definitely where they are, like we get the one with deformities. Most of them, first is a issue of awareness because they don't really know that those problems are treatable. And actually, they think because some you find two, three children in the same family with clubfoot, and they usually think it's a bad luck to the family, and they are not aware that that can be corrected. And we get those one also with malnutrition. It's just because of bad management where they come. Because like the day before yesterday and tomorrow, I had two children with deformity on the upper limb, which we call cubitus varus deformity, and those like the one I had yesterday, that was actually a fracture, which is a standard fracture that was in 2021, but came to yesterday to the hospital because all this time the child was treated only with physiotherapy, thinking that that deformity is going to heal, correct with physiotherapy, and that was in the mind of the parent, and even in the mind of the one who was treated. And means that's a major issue which we have. Means when in those areas there are no people with skills who can treat those problems the way it's supposed to. And that's why what we do, we organize team from our hospital to go in those areas like an outreach program. And we actually, I think we work with churches in those areas, then they will try to identify all the children with deformity, and we go there and we see which one needs to come to the hospital either for surgery or some who just need to do physio, or maybe to give they need some prosthesis and whatever. And when they come, you have to make sure that when you bring them to the hospital, you have to complete the entire treatment before they go home, because you identify them, you have to pay for transport for them to come to the hospital. And during the time at the hospital, you have to provide food and everything because the treatment is free. And you have to make sure that the child has healed, you have finished whatever, because once you release them, they go, it will be difficult for them to come back, and it will just be a wasting of time. Means to complete your treatment, then you let them going back to the community. And I think that's the way we deal with them, and it's actually a successful program because even the one need to come, you send them, they need to come for review. You have again to, when you give them the date, on the date when they have to come, you have to give a phone call to organize transport for them to come, and that's where we manage to treat all those cases. But definitely there are a lot we've come with malnutrition, and without knowing, then they end up with too much disabilities. That's what I can say.
Hey, Patrick, one of the things that we discussed too was child abuse. Do you have issues with child abuse in Zambia? Do you have a mechanism for dealing with child abuse?
Hey, Patrick, did you hear Dr. Headings, or would you like me to repeat?
Yes, yes. The child abuse is there, uh, uh, and I think if there's something which is there's one institution which is well organized for that. I think when you are in big cities, yes, but those one coming from rural area, first they don't even know what are the rights and everything. I think it's actually quite difficult there. But child abuse is definitely a reality here. It's there, definitely.
And what about resource limitations in your hospital? We were talking about the ethics of choosing between, like, if you have two children and they both need a ventilator, but you only have one, who gets that ventilator? Do you find yourself dealing with ethical dilemmas like that in your setup, or are you insulated from that? How does it work at your hospital?
Sorry, I didn't get that properly. Say that.
How do you navigate the ethical challenges with the resource constraints that you're facing? So choosing between somebody having a ventilator versus another child having a ventilator, or between multiple children to have a procedure done.
Okay, definitely. I think if I got you properly, I think what we do generally, because definitely, like in my hospital specifically, okay, children, it's the children are priority. Either they have got, because we have got two category of children. We have got those paying one, and we have got those disabled ones. Now, but talking about selection, I hope I heard you properly. Talking about selection, actually, children, any child come to the hospital is definitely a priority, whatever case it is and everything. But you have first to attend to the children and before any other things. I don't know if that was your question. I don't know.
No, that's a good answer because, Dr. Casa comes from a public institution. Dr. Beza comes from a public institution, and your setup is a little bit different. And so I just thought it would be interesting to hear from your perspective, because you have a lot of child or pediatric pathology. But I was just curious, at your institution where you get charitable donations from overseas, and you've got this different model, how much you feel like you deal with ethical dilemmas in treating children. It sounds to me like you're saying at your institution, you don't feel like you get overwhelmed with ethical dilemmas in treating children.
Okay, yeah. I think we don't have actually that problem, because you see, like my hospital, the way it's designed, like adults, they pay. And all the money which is actually paid for by adults, that's what we use to treat children with. And that's why I was saying that children, whatever case it is, I think a child is a priority to my hospital.
I just love, I love the design of your hospital, and having met the leadership of your hospital and you being part of that hospital, I think it's an amazing hospital. Patrick, thank you so much. Dr. Kokora, Dr. Casa, Dr. Beza, thank you so much. I think we'll call it Lexi, great job as always. Megan, thank you so much for giving that great introduction. She's gone. But we'll close it out here, and have a great day, everybody.